Hello and welcome to Health Tech Builders. Here we explore the business of health innovation through real stories from leaders in the trenches, the wins, the failures, and everything in between. You will get insights and practical advice to help you build and lead in health tech. I am your host, Rodrigo Hute. Hello everyone and welcome back to the podcast. Today my guest is Dr. Samir Abboud. Samir is the Chief of Emergency Radiology at Northwestern Memorial Hospital. Samir was part of a team who developed a Gen AI tool developed in-house at Northwestern Medicine and increased radiologist productivity by up to 40% in real-world deployment. Dr. Sam, thank you so much for being here today and welcome to the podcast.
Thank you so much for having me.
Of course. So I reached out to Sam a few weeks ago after I came across a study at JAMA. There's a JAMA study titled Efficiency and Quality of Gen AI Assisted Radiograph Reporting, June 2025, and I was very excited to see the results, claiming to boost radiologist productivity by up to 40%. And today we have Dr. Sam Abboud here with us to walk us through the study and to share with us what it took for him to change his internal team at the hospital to start implementing, deploying, and utilizing the tool fully. So let's begin with the JAMA study. And for listeners unfamiliar with the study, what was the goal of the study? How was it conducted? Maybe you can walk us through the methodology and what were the key findings?
Absolutely. So the main question we were asking in conducting the study is the clinical use of artificial intelligence, AI generated draft reports associated with documentation efficiency and clinical accuracy for our radiologists. This is really a distillation. It's a smaller version of the question, what are we using AI for and what is the end state of radiologists plus AI going to look like? But for the purposes of this study, we simply asked, is using this tool going to make radiologists more efficient, and will it affect the accuracy of their reports, either positively or negatively? So to answer that question, we tracked the amount of time it took a radiologist to open a report, how long it took them to fill a report, and then how long it took them to sign or release that report, with or without the algorithm. So from start to finish of just the radiologist's job, removing all the other variables of acquisition of the study and all those other additional variables. This gave us a number in seconds of how long it takes a radiologist to generate a report. And from there, we could calculate efficiency gains. We also took a sample of 800 studies that were reported with or without the algorithm. And we took those reports and we shared the reports plus the images with additional radiologists to then grade the quality of the report. And we blinded them as to whether or not the algorithm was used in generating the report. And that was a way for us to measure if there was any decrease in quality of the reports, by which we mean after review with multiple radiologists overlooking the reports and the images, did they find missed findings? Was there a decrease in textual quality? Was there problems with the grammar? Were there issues with the wording? Were there all these things that can affect the interpretation of a report as to whether it's a quality report or not? What we found was eye-opening, eye-popping. I had hoped going into this report that we could show a 10% efficiency gain. And what we found was on average, and this for this study was just for x-rays, the radiologists were achieving efficiency gains of 15+%, with some of the more technologically inclined radiologists who were more comfortable with the technology, were more able to integrate it, finding efficiency gains of 40%, which is a bit of a game changer in terms of what this technology can be used for, I think.
So the productivity boost, it can be a big headline, right? Like for the medical industry, like, oh, you have an AI tool and it's boosting a physician's productivity by 40%. Like, wow, right? So what does that actually mean for radiologists on the ground?
That's an excellent question, and I'm very happy you asked it. There's a couple parts to that question to unpack. So the first thing I will say, and this is the critical point as to that efficiency gain, is that we demonstrated these efficiency gains occurred without a decrease in quality. Because anyone can go fast and do a bad job. The trick is, can you go fast and maintain the quality your patients expect and deserve when they come to a Northwestern hospital or any other hospital for that matter. Um, it's no secret that there's a shortage of radiologists. It's no secret that the amount of imaging in the United States and worldwide continues to go up. And there's just not enough people to read those studies. And so the net effect is we need a way to get more reports, get our radiologists to see more patients in the same amount of time while maintaining that quality. So I really think that this is one of those rare triple wins. For the radiologists, number one, when you log in as a radiologist and when you look at a list of 100 patients you have to look through, there's 100 scans you have to read, 100 x-rays you have to read. That in and of itself is a stressor. So the fact that you can get through that list faster reduces the stress burden of your work a certain amount. Also, it allows you to really do the job of the radiologist. And people always ask, what is your job as a radiologist? And first and foremost, my job is to look at an x-ray or a CT scan or an MRI and decide what is the most important thing affecting that patient and who do they need to see next? Which doctor do they need to go to next? And if I'm generating a report, there's a million little details that go into that report that are important, but are not critical to those questions that are facing the patient right now. And so if I can spend more of my brain power looking at the images and looking at my patient and less brain power editing the indication for the study, less brain power editing grammar mistakes, all of those things add up to make my job less mentally taxing, less draining. So at the end of the shift, I don't feel as drained as I used to. Also, it's better for our patients. If we can get to the next patient faster, it's an additive effect. So if I take care of patient A 40% faster, I can take care of patient B 40% faster on top of that 40%. And so all of these patients that are sitting in the waiting room of the emergency department that, a couple months ago would be waiting 2 or 3 hours for a report to come for their study, we can get them through faster. So we can take care of more patients and get them where they need to go faster, which has a positive effect on the patient's care and on the patient's perception of their care. And last but not least, hospitals are entirely dependent on radiology. So they cannot function unless we can get the radiologists to provide those interpretations for those hospitals. So it's a win for the hospital, a win for the patients, and a win for the radiologists.
Yeah, absolutely. And how on average or what's the median of the number of reads or studies that a typical radiologist has to go through in a typical day?
So that can be affected by the types of studies a radiologist is reading. But if we unpack it, if we look just at emergency radiologists who read typically a mix of X-rays and CTs and some MRIs and ultrasounds, on the low end, you'll be looking at around 100 reads. On the high end, you'll be looking at 140, 150, 170 reads.
Okay, so let's just take 100, right? So if you have to read 100 per day, how much time in your day does it go to reading and understanding and interpreting the images versus how much time it goes to writing a report, preparing the report, sending the report?
That's an excellent question. And I think I see where you're going with this because it's very insightful. Currently, the great secret of radiology is in under a minute you know what's going on with that patient. You look at the x-rays, the CTs, and you know what needs to be done. And then to generate that report, if it's an x-ray, it could be another 45 seconds to another minute. With a CT scan, you could spend another 6 to 10 minutes creating the report, correcting the report, checking for typos. So there is a lot of efficiency to be gained there by removing those tasks from the radiologist's workflow.
Can we unpack a little bit more how does the AI tool actually works? Can you can
Yeah,
you can you give us
yeah.
an example?
So the AI tool, it's ARIES is the name of the tool. It stands for Automated Radiology Interpretation and Evaluation System. Is a very, very clever tool that my colleague Dr. Edamati, I think, incepted in 2018, 2019, around that time. Um, it is a true pixels to paragraphs tool. So what it does is it ingests the images, the current study and the prior study. That's the input, plus the indication and some DICOM header information, some very basic textual information. And what it puts out is full paragraphs, as if a radiologist or a radiology resident had generated the report. So the goal was, how do we get this tool, which is a very nice tool, in front of a radiologist in a useful fashion? Um, and the trick was just to pipe in the text um, directly into our workflow. So, for example, when I'm generating a report as a radiologist, I dictate into a microphone. I have some shortcuts I can use. We call them macros. So if you see things commonly, you can say macro old brain, for example, which includes all the findings that you commonly see in an elderly patient's brain CT. So we have a lot of shortcuts that we use as radiologists. And so we were able to implement the output from ARIES directly into our macros. And what that means was it generates a full report. So when I'm working with the AI tool, I just look at the scan and I form my opinions. And then I look over at my dictation software, and instead of dictating from scratch or pulling up any of my macros, the report is already there and it's ready for me to edit or to sign. And the really nice thing we've found is as the algorithm has improved, is 85% of the reports require no edits from me. So I look at the images, I look over at the report generated by the AI tool, and I sign it. And so from start to finish, on x-rays especially, what used to take me a minute 15, a minute 30 seconds to do to generate that report, we have cut down to 50 seconds instead. And you can see the time savings there. In roughly 10% of cases, there are some minor edits that need to be made, change some findings that maybe won't affect the patient's care but are important to include, or some stylistic changes. And in about 5% of cases, the tool is not perfect. And in some of those cases, it's simply faster for me to do what I call artisanal radiology, just do it the old-fashioned way. But you can see then that in 80 to 85% of cases, there's a huge time savings, a huge efficiency gain. In about 10% of cases, there's still an efficiency gain, but it's smaller than you would expect in the bulk of the cases. And then in about 5% of cases, I break even with my traditional workflow.
So why did you choose to focus on X-rays for this study? What was the decision making for that?
For this study, X-rays were the easiest problem to solve first, simply because it's either one or two views, and then with a prior, it's one or two views, and then some other X-rays might be at most 3 or 4 views, as opposed to CT where you have volumetric data, where you have stacks of images. So computationally, it was easier to start with X-rays. And since that's the problem that we solved first with the algorithm, that's the one that we trialed with this paper.
Yeah, and have you tried the tool with other types of
Yeah,
yeah.
I am happy to say in the time since this paper was published, we've extended the tool so it works for all X-rays, any body part, any X-ray, and it works for all CTs from head to toe. So
Hmm.
I am using it clinically for X-rays and CTs now on almost all of the studies that all of the patients that I see.
What are some of the limitations of the study?
So the main limitation is that we were just at one medical system. So Northwestern is a pretty large medical system. We have 11 hospitals that we've deployed the tool at. We have a varied patient population. We're in Chicago, a major metro area with a large variety of patient socioeconomic status and ethnicity. So we're a pretty good representation of the United States in that regard, but we have not yet tried it at any other hospital systems. Similarly, Northwestern has a limited number of vendors that we use our machines from. Granted, we have 11 hospitals, so we cover many of the vendors, but not all of the vendors. So theoretically, if there's another brand out there of X-ray machine that we don't use at our hospital system, we cannot say confidently whether or not this algorithm would work for those. Although I'm pretty convinced that it's agnostic, and I'm pretty certain that it would work with any vendor, but I cannot say that with certainty, with scientific rigor. The other limitation is that we're doing a repeated measures study design, which means we use radiologists as their own controls because that's the only workflow we have currently. We don't have any other ground truth. So it's not possible to do an independent, double-blind, independently evaluated study. So there's always the possibility that the radiologist who evaluated the reports was also the radiologist who generated the report, which would introduce a small amount of bias in that regard. But we think that by blinding and by having 800 reports, we've mitigated for that to a certain extent. Also,
Yeah.
a lot of the benefits that we talk about in terms of reducing burnout for our radiologists, reducing the mental tax of our job, that's not been measured robustly yet, although that is something that's in the works.
So once you had the data with you, uh, after you completed your study and you saw, you and your team realized like, wow, we have a boost in productivity, whether it's 20% or 30% or 40%, whatever it may be, you saw a real, boost in productivity. So how did you then, go about, or what did you do to operationalize the tool into your daily clinical workflows across the hospital?
Yeah, so that was actually a really fun problem, which presented its own solution because when we were working with the project, when I was the only guinea pig using it, when we were experimenting with it, the results from the AI algorithm were still visible. We're a PowerScribe shop. We use PowerScribe for our dictation software, and one of the features of PowerScribe is that you have panels on the side with background information from the study, and it turns out the results from our algorithm were being displayed in that window pane. And a lot of radiologists who were not on the IRB and who were not meant to be using the algorithm tried to start using it. And that set off alarm bells for us. And our engineer said, hey, this person is trying to use the AI algorithm, which is a good problem to have. People wanted to use it, and they were self-identifying. Because we were on an IRB, we had to put up a walled garden and exclude people to a certain extent, which also generated buzz around this tool. And so when we wanted to take it to the various radiologists in the system, we already had a built-in collection of early adopters, people we knew who were excited about using this tool. So we found one chest radiologist, one bone and joint radiologist, and then we went to all of our community hospitals, which have their own little radiology departments under the Department of Radiology, and we found the champions in all of those different community hospitals. And we gave access, we resubmitted our IRB, and we gave access to these, we called them our champions. And we gave them first user access. No one else could use it. And as people saw the results of the champions local to their department, people talk, they share what's going on. It generated this self-reinforcing feedback loop where people wanted in. People were saying, when can I get access to this tool? Now, it's not everybody. Last I checked, I think we have about 60 active users. There's always going to be holdouts. I mean, there's still some people out in the world today that don't want to use a smartphone, right? So there's always going to be holdouts. But if you can identify those champions and support them and give them the tools they need to use the tool that you want them to use and handhold them through the early phase because of the learning curve or whatever it is, and make the technology work for them, they then go out and recruit from among their peers, and you can get users from that. And so our active user base grew over the course of 6 months, grew from me, one person, to 5 to 10 to then today we're at 60-ish active users. The other thing we had to do while operationalizing it, and this speaks to the long-term implications, is we found that our trainees and our residents were sometimes tempted to use AI as a crutch while they were learning. And we had to build, again, that walled garden to exclude any trainees from using ARIES. And that was a very conscious decision. I mean, yes, we want them to be aware that AI tools exist, and we want them to be able to use those tools, but we also long-term want them to be the gold standard of radiology, and we want them to be very excellent radiologists for the future. So to protect their future as radiologists, we had to exclude them from using the ARIES.
So, so would you say the tool has been rolled out across the hospital, or it's still, or would you say it's still in pilot mode?
I think we are actively using it. It's no longer in pilot mode. It's being used actively at all 11 hospitals by half or more of all the radiologists who are eligible to use it.
Well, that's fantastic.
Yeah.
So how do you then, if it's now being widely used across hospitals, how do you actually monitor its performance and avoid problems? Like model drift or automation bias or something like that.
Absolutely. Those are two very important questions. For model drift, we have a retraining cycle every set period. We retrain the algorithm. And the most important signal we use when we retrain the algorithm is the corrections the radiologists are making. So the reports that require heavy corrections are weighted heavier in the retraining of the model. Automation bias is something that we're always worried about. Our radiologists just signing the reports without looking at them. And we have a dashboard where our engineers track each radiologist, each user, their report sign times. And we do also spot check reports where we read over reports and look at the images and make sure, do our quality assurance that way. And see if there is a difference in the misinterpretations or misses with or without the tool. And then the biggest alert would be if someone was signing a report instantaneously, that would set off an alarm bell as well. I mean, radiologists can be fast, but they're never going to be instantaneous. So that's something we watch for.
What did you do to, I mean, you already talked about early adopters. There's always a small group of early adopters once you have a new technology. But what did you do to lead the change and to evangelize the tool amongst your peers and other radiologists? And how did you win them over to start using the tool?
I love that question because that was actually a very fun part of my job. We called it the dog and pony show. So we went to the different sections have their section meetings, once a month or once a quarter where they get together, they talk about the things impacting their daily workflow. And we just asked them if we could join their section meeting. And we went in and I showed them, this is what I do. This is how I use it. It's this easy to implement it. We have some, radiologists who are less technologically facile, so they would need more hand holding where I would actually walk them through every step. I would take control of their screen and I would deploy the tool on their workstation for them to make it as seamless as possible, single click. And this is something that could be handled long-term by, someone from IT, or it could be deployed on a workstation prior to sending it out to a radiologist if they were, a new hire or something. But I felt it was important at this stage just to be radiologist to radiologist to walk them through the steps. Um, and that was the biggest factor in incorporating people to start using it. We also used a dashboard, and we anonymized the names of the radiologists, but we shared a website where they could track live the efficiency gains that radiologists were getting. You could see, a graph, and you could see radiologist A, and there's no way to know who radiologist A is because we don't want to, embarrass or shame or make it competitive. But you could see if you're watching the dashboard, you can see radiologist A efficiency gains go from negative 5% the first month because they were still learning how to use the tool to 10% to 15% to 20% plus, and you could see that graph. And sharing that data is almost like a gamification, but that really did help people see the benefit. We're also in a very interesting inflection time in radiology in general. Again, because I mentioned, we have the shortage of radiologists, and many hospital systems are trying to figure out how they can incentivize productivity from their radiologists, which means that as you look at, particularly in the employed radiologist model, the compensation structures are being built to incentivize doing more. And as you can imagine, what is incentivized is what gets done. And so if you have that combination of there's a production component to someone's paycheck, and there's a tool that can help make them more productive, any rational human being would want to combine those two things. And last but not least, I want to focus on, you mentioned holdouts, because I love the holdouts, and I love the grumpy people who have the most complaints, because that's our opportunity to improve. And the example I can give is some radiologists are very, very picky about their words. While it may convey the same diagnosis, using different words might be very important to a particular radiologist. And so we asked ourselves, what is preventing this radiologist from using the tool? What is slowing them down? Why are they not using it? And it turns out they were correcting a ton of reports to change the words around, making the same diagnosis, but they were wasting a lot of time just changing the words. And so I asked the engineering team, and this is what I really, really love about our setup. The engineering team is in the hospital. I asked them, can we add an extra layer on to make the reports in the radiologist's own words? Just add the interpreting radiologist to the algorithm so they know who's reading it, so we can put the report in their own words. And we found that one small change improved uptake. So radiologists were more likely to use the tool because it was in their own words. And it also improved their efficiency gains because they were no longer taking the time to change the word degenerative disc disease to spondyloarthropathy, right? They didn't have to make that change. It was already made for them. It was in their words. And so that was a double whammy, and that came about because we had these picky holdout users.
Mm-hmm. Yeah, I can imagine. So most hospitals buy software off the shelf, typically. So in your case, it was different. So you decided to build your own platform, your own Gen AI tool in-house. So how was that decision? The decision of build versus buy, and why did you feel confident that you were going to be able to develop a really cutting edge tool inside the hospital?
Yeah. So we're very blessed at Northwestern. We have a very thoughtful leadership with a long horizon vision. And we have an institute within the hospital, the Mansueto Institute, which is done for innovation and those sorts of things. So that, in part, funded a lot of this project. But also, and I think a critical part of this is with the rise of these Gen AI tools and small language models, it's been wonderful democratization of this approach in that if you pick the right problem, almost anyone can come up with a workable solution. Um, and all it takes is a honest question, an honest session where you sit down and you ask the questions of what are your goals, what is the scope of your goals, and who are your key stakeholders. So for us, we sat down, we asked who are our end users? Our end users are radiologists. Who are our implementers and maintainers? That's going to be the IT people. And at Northwestern, we're blessed. We have well invested in our IT infrastructure. We have top flight IT informatics, not just in radiology, but I think throughout the hospital system and throughout the clinical services. Who are going to be your monitors of performance? Do you have data scientists on staff that can handle that? Thankfully, at Northwestern, we do. And who will guide your strategy? And again, at Northwestern, we're very lucky. We're blessed with leadership and administration that has insight into these things. And once you've set your organizational goal, you can do an honest needs assessment. So I think at the beginning I mentioned the question is, what problem are you trying to solve with AI, and how much improvement can be expected? And as we work through these questions, we found that at Northwestern we had all these tools available. We had talented electrical engineers, software engineers. We had a funding environment where we could hire a certain number of engineers if we needed them. And we had a radiology department that A, had the infrastructure to support the tools deployment, and B, had the willingness to try it out. But I think that to get a solution like this, I'm not surprised that it occurred at a Northwestern. This is the environment where those sorts of things happen. But if you take a step back, and by you I mean any radiologist in any department, if you take a step back, if you conduct an honest needs assessment, and if you conduct an honest survey of your stakeholders, you can identify a problem that you potentially have the tools to solve without necessarily using an off-the-shelf vendor. And even if you don't have the tools to build it yourself, identifying your stakeholders and doing an honest needs assessment will allow you to better select the vendor you should work with and better identify what your KPIs are going to be and what sort of metrics you really want to focus on with the vendor that you select.
So what's next for Aries, for the tool? Do you see this evolving into a clinical decision support tool for the hospital? Do you see this, are you thinking about broadening modalities into, other types of images, MRIs, etc.?
Yeah, there are so many avenues, and this goes back to the difference in philosophy and how we developed Aries versus what's available from most vendors today. So Aries, I like to say, is holistic. It's outside in, it's pixels to paragraph. It looks at the whole image, it generates a report in natural language. As opposed to what you see most commonly on the market today is you pick one disease, you generate one algorithm. You pick one disease, you generate one algorithm. And what's so very beautiful about Aries generating a whole report is it's much easier to then interrogate that report for any critical diagnoses you want. And this was a second part of the paper where we talked specifically about pneumothorax, which is a collapsed lung. And I'll give the example of pneumothorax because it occurs frequently. And if it goes undetected or untreated, in certain scenarios, it can be rapidly fatal for a patient. So of course, there are many vendors out there that have developed algorithms to detect pneumothorax, and they say 99 point whatever % sensitivity and specificity. We have this wonderful algorithm that will look at your x-ray and detect a pneumothorax and elevate it to the top of your work list so you know you need to look at that x-ray right away because it has a pneumothorax, which is helpful, right? But if we look at a system like Northwestern, we have 11 hospitals with ICU beds. Many of the patients in the ICU will be post-surgery patients where they might have a pneumothorax that is expected because they had surgery. or there might be patients who have a pneumothorax that already have a tube in a chest tube to reduce that pneumothorax. So even though these algorithms off the market detect the pneumothorax and alert you to it, which is helpful, they don't specify if it's a new pneumothorax, if it's an unexpected pneumothorax, if it's an enlarging or life-threatening pneumothorax, because they can't. So you get flags, but you get a ton of flags and you get flag fatigue. But what I love about what we've done with Aries is we put a layer on top of the report where we asked, number one, can you detect a pneumothorax? Number two, can you tell me, was this pneumothorax there before? And if it was there before, is it getting smaller or bigger, or is it the same? Is there already a chest tube there? Is this a patient that had surgery? Do we expect them to have a pneumothorax? Or is this a patient who has a known pneumothorax? I don't need an alert about it. And we implemented it across the system, so 11 hospitals. And instead of getting 20 to 30 alerts a day using the more traditional approach, I was the guinea pig for this trial, and I would get 1 or 2 alerts a week. But I knew when I got an alert, I knew it was a real alert, because I knew it was a pneumothorax that was getting bigger or a pneumothorax that was unexpected, right? Because those are the ones that I care about, not the ones that have been there for a week. Those are not important. Unless they're getting bigger, that's not an important pneumothorax for me to know about, to elevate my my work list. And that was a proof of concept we did with pneumothorax, but you can imagine that can apply to any disease process. You can pick any disease process and you can generate a flag for it, and you can filter those flags so that we don't suffer from flag fatigue. The other thing we've discovered is that, Aries, the algorithm works great for CTs. We figured out how to stuff all the images into the pipeline, how to investigate them, and how to spit out a report. And so it's no different from the workflow for X-rays. And so we've been using, for over 6 months now, we've been using Aries for X-rays and CTs. I think we're in the tens of thousands of interpretations now that have been done using Aries. And it only makes sense to do MRI next, ultrasound. It's the natural progression.
Right. So, in terms of, I have a final question before we wrap up. And you and I, we've talked about this before, but I wanted to, the audience to, learn from you. So how do you see the role of the radiologist evolving, now with AI? How do you see it evolving over the next 5 to 10 years? So there's a open debate about whether AI will replace radiologists, whether AI will empower and support radiologists. Is it going to be a hybrid? So people have different opinions, but what's your honest take in terms of how the role of a radiologist will evolve?
Yeah, I think of necessity, radiologists with AI tools are going to replace radiologists not using AI tools. I think the future will be, if I told you today that an average radiologist is going to read 100 studies in a shift, I think the future will be that radiologist is going to be reading 200 to 250 in a shift. But with the correct application of these tools, they'll be potentially less stressed and less fatigued after that shift, even though they're doing 2 or 2.5 times more work. I think a lot of the administrative burden of generating reports, of shuttling patients, of protocoling studies, of answering questions about studies will be offloaded and will be handled by AI tools. And then your job as a radiologist will be to perform at a very high level as a radiologist, to perform quality assurance as the AI does the bulk of the work. I also think that we have to preserve our radiology trainees and our junior radiologists as the future gold standard, as the North Star against which AI will be measured. Because you mentioned there is drift, and not just drift, there's new devices will be implemented, new imaging techniques will be devised, and all of these change your patient population and therefore change uh, the environment in which the AI is operating. And you cannot say with certainty if your AI is functioning correctly or not unless you have a QA method, which is that radiologist that serves as the North Star. And the example I give is, we had a chest X-ray, and there's a new device that was implemented in the last few years called a leadless pacemaker, where, a patient, instead of getting a pacemaker in their chest with wires that go to their heart, the pacemaker is so much smaller, it just goes right in their heart. But this was a device that Ares had never seen before. So Ares saw it, recognized that there was something metal there that shouldn't be there, but didn't know what it was. And it said, oh, there's a metallic foreign body in this patient. And as a radiologist, I could say, oh no, I'm staying up to date, I'm keeping myself fresh. That's a leadless pacemaker, and I could make that correction. Now we're a few months in, Ares has been retrained, it now recognizes those. But for that brief period of time, you needed a radiologist for that retraining, until that retraining could be done.
Also, I can see AI boosting and improving productivity by a lot. And but at the same time, someone has to be responsible and someone has to sign off a report, right? So I don't think the FDA or other government regulators will allow AI to be signing off
Yeah.
any reports anytime soon. So
Yeah, I mean, even with the very best AIs, let's say 99.5% sensitivity, right? That's a nice number. Um, I mean, we see over 1,000 patients a night, so that's 5 patients a night that potentially could be affected by a misread from AI. So the quality assurance from the radiologist is critical. I agree.
yeah. All right. Any final comments, Sam, before we go?
I'm just very, very excited for the future of what all these tools will bring. And I like what we've done at Northwestern, and I very much would like to see this tool being used, or something like it being used, by all radiologists, just because it makes our job easier. But I'm very excited by the possibilities of the garage businesses where radiologists are at home, they're tinkering with their Python scripts, and they're generating these tools for themselves and solving the problems that they have, which then can be shared with other radiologists.
Yeah. All right. So, well, first of all, congratulations. I think it's fantastic what you guys have built at Northwestern. Congrats on the publication of the paper as well. And thank you so much for being here today, for sharing your wisdom with all of us. So thank you
Thanks
so
for
much.
having me.
Until the next time. Thank you so much, everyone. Bye bye.